We might get started, and others who need to join will join when they can. Welcome to the 12th Advocates and Allies webinar. My name is Evelini Tadros and I am the CEO for the Mental Health Coordinating Council. These events aim to build the capacity of mental health and psychosocial support workers to increase their understanding of diversity of themes relevant to their work in the sector. In the spirit of reconciliation, I would like to start by acknowledging the traditional custodians of this land, the Wangal and Gadigal people of the Eora Nation, and I pay my respects to their elders, both past, present and future, for they hold the memories, the culture and dreams of the Aboriginal and Torres Strait Islander people. I recognise and respect their cultural heritage, beliefs and continued relationship with the land. I also acknowledge that the Uluru Statement of the Heart humbly remains an open invitation to support closing the gap. I also recognise those with lived and living experience in mental health challenges, their advocates, allies, kin, support network. Your experiences continue to inform the work that we do, and I also extend my empathy and understanding to those who remain private and silent about their mental health challenges and or experiences. Just a little bit of a warning. I would like to just alert participants today that we will be discussing matters that some people may find distressing. So I urge you to do whatever it is necessary to take care of yourself. Just to provide a little bit of context to today's webinar, a proposed Australian Human Rights Act is under consideration nationally and in several states and territories. Recently, there has been considerable discussion about adopting a human rights approach in the mental health and human services, but of particular interest to us in the community managed organisations sector is what this might mean on the ground, especially in the context of working with people under involuntary treatment orders, living in a community-based context, and about how the Human Rights Act might assist us at a practice and service delivery level. We are in the fantastic position of having three extremely knowledgeable presenters who are all going to put their cameras on just so that I can introduce them. And they're going to help us garner more insight into some of the tensions, challenges and opportunities the Human Rights Act may throw at us. It is with great pleasure that I welcome Emeritus Professor Terry Carney, Associate Professor Piers Goodney, and Professor Sharon Lawn. It is with great pleasure that I welcome our first presenter today. Terry Carney, AO, is Emeritus Professor at the Law School, University of Sydney. He is a Fellow of the Australian Academy of Law and past President from 2005 to 2007 of the International Academy of Law and Mental Health. The author of nearly a dozen books, monographs, including books on mental health tribunals and anorexia, and over 250 academic papers. He is currently an associate investigator at the ARC Centre for Excellence for Automated Decision-Making and Society, writing on issues of automation in social security, law, welfare services, and the NDIS. Please join me in welcoming Terry, and I'll hand over to you, Terry, if you want to just start screen sharing, and I'll make sure, yep, you're good to go. Thank you.
Thank you very much. It's a delight to be present. Have I got my microphone on?
Yep, you're good to go.
Yeah, I'm good. Yes, it's a delight to present. I'd like to acknowledge the land from which I'm presenting down at the Shoalhaven, the Jeringer clan of the Wandjiwardian people, and I acknowledge their elders past, present and emerging. The slides I've got in the 15 minutes or so that I'm going to speak set up around the theme of whether a Human Rights Act or a human rights perspective is likely to make a significant difference or not in the mental health space. And the answer to that is not a lot, at the margins or small, however you might like to phrase it. So in putting that proposition, that it's an important addition to the quiver, to the portfolio of measures to make lived life better for people with mental health conditions, but not a lot. First thing I'm going to talk about is why or why not have a Human Rights Act. Second thing I'm going to do is talk about the civil rights balance sheet so far. Civil rights are involved whenever coercive power is used to prevent a person from doing something. So it might be involuntary detention or involuntary treatment. They're the sorts of issues. And then thirdly, I'm going to talk about what I think is by far the most important issue, and that is what difference is made in relation to getting access to services, supports, community support, and so on. And they're called socioeconomic rights rather than civil rights. And then there are some references at the end, so don't worry when you get short statements of on the screen of the things that I'm mentioning. Okay, so the first question is why or why not have a Human Rights Act? Well, Australia is the only, as a country, is the only liberal democracy not to have a Human Rights Act at the national level. And the current debate, as has already been mentioned, is about whatever it is, about the third attempt by different governments to contemplate having a Human Rights Act introduced so that we'd no longer be the only liberal democracy without one. But putting, even assuming that we get a Human Rights Act at the national level, and assuming, which can't be given, that it will include provisions guaranteeing socioeconomic rights, rights to services and so on, it'll make hardly any difference because so far as mental health services are concerned and people with a mental health condition, it's the states and territories that under our Australian Constitution and division of responsibilities and law-making powers between the national and the state and territory governments on each hand, it's the states and territories that are responsible almost without exception for everything that matters. So the only main sort of exception to that is that because of the way the taxing powers, there used to be state income tax, well, still is a state income tax power, but it's permanently given to the national government. And as we all know, the national government is able to raise more revenue proportionately than the states and territories. And the national government uses its ability to raise money to enter into agreements with states and territories, whereby in return for money that they don't have, for services that they've desperately need money to deliver to their citizens in the state or territory, that in return for that money, that the Commonwealth will impose certain conditions under a national and state territory agreement, contract really, a contract between the two levels of government. So there is some space for national leadership and priority setting, but not a lot is the point I'm making. So the next fly-in dot point on this slide draws attention to the fact that in 2004, the Australian Capital Territory, in 2006, Victoria, and then in 2019, Queensland, did at the state level, state and territory level, introduce a Human Rights Act to govern the way law and administration is held to account against certain human rights standards. Those standards are not exclusively, but they're principally almost exclusively concerned with the protection of the individual, the civil rights, and those human rights acts do not really do anything or do not purport to confer socio-economic rights to services. Three places have got them, but the places that have got them, they're not really addressing the main game, and the main game is whether a person with a mental illness is in a position to get the kind of services and supports that they need. The second thing to say about Victoria, Queensland and the ACT is that the Human Rights Acts in those jurisdictions are weaker than, say, the one in the United States, which trumps, no pun intended, the pun is intended, I suppose, which trumps the legislature. In Australia, we've gone for what is called the dialogue model, whereby if there's an adverse ruling that there's a breach of human rights conferred in the Act, the Parliament still has the option after that verdict, if you like, is handed down that there's a breach of human rights, still has the option of legislating to reverse that conferral of that right. And in Queensland, in the juvenile justice space, we've seen that power exercised in recent times to authorise the really an abomination, the detention in state police watchhouses of juveniles, something that's a flagrant breach of anybody's interpretation of rights of children. So the other thing to say about the possible contribution that comes from enacting a new Human Rights Act at the national level, or in those states that don't already have one, states and territories that don't already have one, is that it can, that there's a legitimate argument that it helps to elevate the change the culture, if you like, of community dialogue, and it boosts the strength of the argument for thinking about whether and what kind of rights people might have, and in what ways those rights might be threatened, or in what ways steps could be taken to protect and enhance those rights in settings like mental health facilities or community mental health programs. So we talk about that as the rhetoric of rights talk, and there are two papers back in 2000, a paper in 2008, and the book that my colleagues and I wrote in 2011, which was an investigation of mental health tribunals in New South Wales, Victoria, and the Australian Capital Territory. Okay, now I'm keeping an eye on the clock. So to the next question, the more important sort of issue, what kinds of rights? I've already indicated that the right to be left alone is very different from a right to services, and it's the right to be left alone or not have involuntary powers unreasonably exercised against one that is the subject of the three acts that I had on the screen a minute ago. But human rights legislation in practice, even when a Human Rights Act does include socioeconomic rights, as currently we don't in Australia, even in the places where we've legislated for a Human Rights Act, even when you legislate a right to health, for example, and it's the right to health which is where mental health is a subset of the right to health, and where one could argue for leverage for adequate provision of mental health services and supports and participation in the design of supports, those kinds of arguments. Well, it's one thing to have the right. What international practice indicates is that it's very hard to there's not a lot of success in human rights instruments in holding governments and service providers and citizens to account for the sentiments that are spelled out in something like a right to health or a right to education. There are some exceptions to that in Victoria. My colleague Piers Gooding, I think, is going to say a bit more about some of these cases. But in 2009, there was a ruling under the Victorian Charter. The Charter is just a better label for a Human Rights Act of the dialogue type that I was indicating is the only type that we have. It conferred some rights to prompt a review, quicker review of a person's status. That's what that case stood for. In 2018, the case that's sitting there second in that dot point said, look, capacity testing of a person's abilities, capacity testing of the sort of traditional medico type is not compatible with the Charter. An alternative way needed to be found to determine to make the kind of decision that was an issue in that particular case. Something closer to assessing the person's ability to do something or not do something, rather than apply some rather artificial medical tool that assesses their capacity. What I've just put on the slide there is the New South Wales case. New South Wales doesn't have a charter, but there the common law courts found that there was a basis for finding that the least restrictive alternative principle meant that somebody was entitled to have their community treatment order medication as a long-lasting injection rather than be required to come in day by day, which was very inconvenient for their work and living arrangements and so on. But basically, there's no real rights in the space, and no socioeconomic rights being conferred. And the Tasmanian Law Reform Commission recommended it a long time ago, but neither Tasmania nor anybody else adopted it. I see that I'm just about on time, so I'm kicking my screen along. And so what might we do in the future? Well, I think the sentiment of the Victorian Royal Commission report of localising control, the local boards, the regionalisation and sort of accommodating the variation that you get across different parts of the geography of a state like Victoria. I think that's a sensible goal and objective, and a good way of improving the life of people with mental illness in terms of access to services. But I'm well aware that the timetable that was laid out by the Royal Commission and initially by government in adopting it is running at about half pace or less at the moment. The second thing, and Piers might say something about that too, that some of the Convention on Rights of Persons with Disabilities sentiments about supported decision-making, I think that has given some momentum in the right direction towards a little bit of a nudge towards greater consumer control and power and so on in relation to requesting and obtaining access to services. But as we found in our research, and that's the bottom part of that slide, what consumers are mainly wanting is some rights about choosing the kind of medication they have or don't have, having more control over access to housing support or assistance in obtaining and retaining employment and so on. And there's no leverage, nothing that human rights or anything else is directing to that critical space so far as the lived experience of people is concerned. And finally, as I'm 3 minutes over, there are the references that I've been referring to previously. Apologies for running a fraction over time, but thank you.
Thank you so much, Terry. Did start late, so you're actually fine on time. And just to reassure everyone, you will actually get all these presentations following the webinar. And thank you to the presenters for agreeing to do so. Terry, I understand why you've done over 250 submissions on articles and so many books, because it's such an interesting topic. So thank you for your time. I want to reassure everyone that we're going to have a panel discussion later. I can see 2 people with their raised hands. If you don't mind putting your hands down for now, and during the panel, I'll allow you to kind of put your hands up and we can have some Q&A at that point. There is also a Q&A section or panel, or it's a segment down the bottom that you can click on and put your Q&A in there in the meantime. So thank you for your patience. It is now my pleasure to introduce Dr. Piers Gooding, who is an associate professor at La Trobe Law School. His work focuses on mental health law, policy and practice. He is the author of A New Era for Mental Health Law and Policy, Supported Decision-Making and UN Convention on the Rights of Persons with Disabilities, which was published in 2017, and is on the editorial board for the International Journal for Mental Health and Capacity Law and International Journal of Disability and Social Justice. Piers has worked with a range of international organisations and agencies, including the UN Special Rapporteur for Rights of People with Disabilities and the Right to Health. He also advised the World Health Organization. Such a pleasure to have you here with us, Piers, and I'll hand over to you.
Thank you so much, Evelyn. It's a real pleasure to be here. And I too would like to acknowledge the traditional owners of the land on which I'm on, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present and emerging. I'm going to sort of try to build on what Terry has described and offer some reflections on the changing role of human rights, particularly since the Convention on the Rights of Persons with Disability, or the CRPD, and what that might mean for those in the community service provision sector. I'll probably focus a little bit more on New South Wales. And my main message really might sound counterintuitive for what you expect someone working in a law school to say. And in some ways, it builds on what Terry has said. And that is to say that rather than looking to courts and legislation, where common sense understandings about rights often head, I'd argue that overall the courts and legislation are going to be unlikely to be the place where you see robust sort of rights protection, promotion and fulfilment. And then instead, for the mental health context, I think the power to uphold or indeed threaten rights lies more in the many thousands of encounters between people who experience mental health crises, their communities and the services that they receive. And they're at stake really when an individual opens their home to a community mental health worker, when a person arrives at a hospital, when a family is sitting around a kitchen table discussing what to do about a particular crisis, or when a team of practitioners is having a meeting decide on a particular approach, or in the boardroom of services in deciding how to spend funds or commission services, train staff and so on, and responding to organisational risks. So clearly, all of those encounters are framed by law and the law has a role, but nevertheless, again, rather than courts and lawyers, I'd encourage you to think about rights as something best realised in those encounters through the sort of creativity and knowledge of people involved, particularly in those lesser seen encounters in mental health, community mental health services. So when an individual support worker or clinician or service provider makes judgments about a particular course of action, I do think an approach that's cognizant of things like the CRPD can really facilitate greater awareness and really improve the quality of those decisions. And a Human Rights Act, if indeed we get one, would ideally bolster that kind of decision-making. Something people can point to say, no, come on, this is a commitment where we as a country or a state have made, and there may be recourse for justiciable action, action through the courts in certain circumstances. So I'm going to try to round this argument out, and I'll start with a bit of background. Human rights obviously were a part of the discussion during the closure of large-scale psychiatric institutions, a major sort of social reform change we've seen that shows what's possible. And you can see that in laws like the Mental Health Act of 1990 in New South Wales, particularly for civil rights, as Terry has mentioned. But there are at least two major things we can say about these laws now from a rights-based perspective. And one is that they utterly failed to secure economic and social rights, those access to services that Terry mentioned. And the Royal Commission into Victorian Mental Health Services here argued that one of the reasons the mental health system was failing is it's so lopsidedly focused on people in extreme mental health crises, because the law goes to people deemed to meet the criteria for involuntary intervention. And it focused so heavily on that people who are saying, you know, I need help or I'm going to end up in extreme crisis aren't given the support they need, because clinical services will say, well, come back to us when you're at that extreme state. But second, and maybe a bit less agreed upon, some have argued that mental health law's rights-based language sort of contradicts the lack of real rights protection that the law offered in practice. And there were two reasons for this. In a way, it codified medical authority to treat and detain. And this was an argument put forward by a UK academic, Phil Fennell, because it's very rare for courts to uphold the refusal or tribunals for any given patient. That's, again, more controversial, but some people might say, well, that's a sign that clinicians are generally getting it right, whereas others will say, well, that's a sign the tribunal is giving a sort of superficial legitimacy to the previous system of unfettered clinical discretion. Now, that's controversial, but to move on, the second thing is that the laws create a sort of separate and special set of rules for people with a mental health condition, because whereas in general health, a person who has decision-making capacity can refuse life-saving treatment like chemotherapy. In mental health care, even someone with decision-making capacity in states in Australia, some states, cannot refuse psychiatric intervention when the criteria for mental health legislation is met. There's a risk of harm to others or the self, and there's no less restrictive option. So the concern here is that at worst, it creates an unconscious and at times conscious tendency to perceive the person as having less human value than others, I suppose. So turning to the convention, much can be said about the CRPD, but for me, I think its major contribution, and this builds on Terry's point about rhetoric perhaps, is to really challenge the long-standing, highly deficit-focused, highly medicalised and welfare-based approaches to disability and mental health policy that traditionally characterised Australian social policy in the 20th century. And in law, that kind of approach led to what Rosemary Caius, who's the current Disability Discrimination Commissioner, characterised as a minority rights approach to policy solutions, which advanced this idea of sort of separate and special treatment for particular disability groups, of which the mental health laws are arguably that type of separate and special treatment. But in contrast, the CRPD promotes this universalist idea aimed at transformative equality. Now, those are very big motherhood statements, but I suppose, in short, it's premised on this idea of disability as one aspect of human diversity, as a natural part of the spectrum of what it means to be human, which requires mainstream laws, policies, and service provision to be reshaped to accommodate this much more realistic account of being human. And this is in contrast to the positioning of people with disabilities as vulnerable sort of special interest groups rather than as normative citizens. And there's a quote here I've got that I like from Jerome Bickenbach and colleagues, who wrote that disability is not a human attribute that demarks one portion of humanity from another. It is an infinitely various but universal feature of the human condition. No human has a complete repertoire of abilities. Now, turning to Australia and the CRPD, given it doesn't have force of hard law, as Terry said, and even with the Human Rights Act, it's unlikely to have anything resembling the kind of hard law that you might see in the US or Germany. What's important about it for our purposes then is what Oliver Lewis describes as its expressive, educational and proactive character. Again, this idea of changing sort of language and maybe mindsets. And none of that is to say that the CRPD isn't in some ways complicated. One of the challenges of the convention is that there's real disagreement about whether it's ever legitimate to have some kind of involuntary psychiatric intervention, because even within the UN, there's disagreement about this. And it's been summarised in the following way. The watershed question might be posed as follows. Can coercive treatment ever comply with human rights standards? The answer from one part of the human rights system seems to be yes, provided some conditions are met, like having mental health tribunals and so on. But another part of the same system seems to be pointing towards an exceptionless no. Now, the Australian government has very clearly indicated it's in the yes camp, and as Terry and I have argued, there's no sign that any Australian government will repeal mental health legislation altogether in the short or medium term. And there was a risk, I think, that this disagreement would lead to a sort of deadlock where no one could agree on anything. But there's a few reasons why I think this isn't the case. And that's because there's a bunch of points of agreement across both sides. And that's that many coercive practices are unacceptable, can cause serious harm regardless of intent, and that even if it's accepted that coercion might be necessary in some circumstances, should generally be viewed as a system failure. And even those who call for complete repeal of any form of coercion will seemingly require evidence to assist in a transition to quality, voluntary-only forms of support. And my colleagues and I in different areas have argued that these points of agreements could really help push action and implement change where necessary, and particularly in service provision. But given I'm in Victoria, I thought it would be helpful to turn to the Charter, which covers mental health service providers as public authorities under Section 4. And the Charter requires those services to do two things. One, properly consider the rights implications of a particular decision, and two, act compatibly with rights. And if asked, justify those decisions. The intention of drafters was to avoid recourse to courts and encourage service development. But there is some provision to allow someone to bring a claim to say that a particular public authority hasn't duly considered human rights implications of a particular decision. But I'll stress, and this underscores what Terry said, if there's a finding of unlawfulness, the claimant can make, get some relief or remedies, but only if there's some other ground of unlawfulness, like a tort of negligence or something. But damages can't be awarded solely for a breach of the Charter. And then the legislature could go back on what's provided as well. So it doesn't provide the kind of robust legal instrument that some people might hope or expect. And there are resources on what it means for mental health services, including by my colleagues, Associate Professor Chris Maley and Simon Cotterell. And Cotterell has pointed to several aspects of service provision that would help fulfil these aims of considering and acting compatibly, including changing outcome measures, sort of changing service outcome measures to align with human rights, commissioning services that are broadly considered to affirm rights, which are genuinely less restrictive and sort of meet some of those other rights, like the right to live independently and in the community. Governance of services with boards showing they've properly considered and complied with rights and clinical governance processes, and in staff onboarding and training, incorporating things that promote human rights like supported decision-making, cultural responsiveness in the Indigenous context. So that's how the Charter could be used. But I also did want to put something in perspective. A common criticism of human rights is that when it comes to combating the unequal distribution of resources and achieving some of those socioeconomic rights, that human rights can be a bit of a wet lettuce. Now, it's notable, I think, that in 2000, Victoria was agreed to have had the best funded mental health services in Australia. The Charter appears in 2006, but by the time our Royal Commission was announced in 2019, there were signs it was faring pretty poorly. And where once Victoria had the highest per capita spend on mental health care, by 2019 it had the lowest, and funding to community-based support and inpatient beds failed to match significant population growth, leaving the state with the lowest number of full-time equivalent staff per capita. I'd say there's also a bit of a question mark about the capacity for human rights as a concept to tackle rising inequality writ large. for which there's pretty good evidence that inequality is a significant social determinant to poor mental health. So this is to put mental health in context, not to dismiss it, not to elevate it, but to put it in context. And I'd also say there's good evidence to say that claims that services can't make changes because of a lack of resources don't always stack up, because there are services in low resource settings here and elsewhere in the world that do show it can be done. And among the emerging resources for guiding that change are the World Health Organization guidance on community services, which forms part of a suite of WHO resources called the Quality Rights Initiative. And it's really a detailed step-by-step guide for policy and service provision. But more locally, the South Australian Office for the Chief Psychiatrist Human Rights and Coercion Reduction Committee developed this human rights analysis tool, which I'd really stress as being valuable for service providers, and Sharon might speak to South Australian innovations shortly. But it really reflects efforts by psychiatric bodies working in this area, including a 2021 World Psychiatric Association position statement on implementing alternatives to coercion, which the Australian New Zealand College, I should say, was quite prominent in advancing. So finally, just a note from Victoria about the new Mental Health and Wellbeing Act and how it was designed, at least in theory, to complement some of these efforts. The Act includes an explicit provision that requires services to implement coercion reduction initiatives and a legislative mandate to expand voluntary services. And Terry alluded to this kind of more local governance arrangement. Now, how successful that is remains to be seen, but it certainly looks hopeful. And there are benchmark indicators to this end to be monitored by a new Mental Health and Wellbeing Commission. Though if you look at what they have to do under the Act, there's about five to 10 different things they have to do. So how they'll achieve all that, I'm not sure. But it does comprise significant lived experience membership. And these efforts are supposed to make involuntary treatment genuinely a last resort and work to elimination of seclusion and restraint, which are among other measures that are framed in much more concrete terms. There is also an opt-out model for non-legal advocacy for anyone under or at risk of compulsory services. And I think community mental health services could learn a lot from that particular innovation, which I think is a global innovation as well. So that really brings me to the end of what I wanted to say, which is that my message to services in this growing body of work seems to be that there are program and guidance materials that can assist in this transition to kind of human rights-based practice if you sort of adopt that language, and that the WHO materials and the South Australian work are certainly among the most comprehensive, and that are some of the others that I referenced here. And the rest, they really do rest on this call for services to commit to being at the forefront of change. And they stress that human rights shouldn't be used, I suppose, as a checklist exercise, but rather as a kind of constant prompt to evaluate what services are for and how control can be shared with the people for whom those services are designed. So perhaps I'll leave it at that and pass on to Sharon. Thanks very much.
Thank you so much, Piers. It's very practical and pragmatic in terms of, not necessarily having an act, but having a charter. And I particularly like the slide where you talked about considering and acting compatibly with human rights. So, outcomes and measures, commissioning services, governance, etc. So really helpful and much appreciated. Just reminding everyone, if you've got questions, please use the Q&A tab at the bottom and put your questions there, and the panelists will be answering them live later on. So it is now my delight to introduce dear colleague Sharon Lawn. Professor Sharon Lawn is the Executive Director of Lived Experience Australia. Sharon, if you want to put your camera on as I'm introducing you, that'd be great. Sharon has over 24 years of lived experience advocacy and a similar period as a mental health researcher focused on consumer and family perspectives and experiences of healthcare systems. Professor Lawn is involved in a number of state and national committees, including as board director for the Australian Self-Care Alliance and a fellow board director with Mental Health Australia. Over to you, Sharon. Thanks for joining us.
Thank you, Evelini. Just share my screen.
Thanks, Sharon.
Okay. Thank you, everyone, for coming along today. I get the privilege of talking from the real and from the lived experience. I'm going to start with a sad start, but I hope to finish on a more hopeful end, because ultimately hope is the most important thing that we have. People have often thought, well, what drives talking about mental health in human rights? For me, it's very clearly an actual example of the loss of a person who I regarded as a brother in a seclusion room in mental health services. So about 10 years ago, I won't go into the detail, but through ultimately the mental health staff not actually seeing that person as human, he passed away in seclusion. It was very evident as 3 nurses watched a CV screen that they were not seeing that person as a person. There was clear issues of stigma, prejudice, assumptions at their worst, that he was just acting up, he was just a drug user, he was just this, that, and whatever else. They failed to respond because they didn't view his calls for help as he was dying. They misinterpreted it as misbehaving, being disruptive, even though they could see him on the screen and they could hear him because the seclusion room was right next to the nurse's station. So it got me thinking about human rights, obviously. And, you know, what is it that, why do we need human rights when some of these things are just calling us to be a more decent society? What is it about services? Why does it make presumably good staff do bad things? Why do we need an act in order to get staff and get all of us to do those things? There's something that happens within systems and with services where people forget who they're serving somehow. It changes people. So this is why more and more I think having a Human Rights Act is so important. Service culture just seems to dominate, and a service-centric view rather than a human-centred view becomes the norm. So for the person that I cared about, the excerpt at the bottom is from the coroner's report. So you can see from that in a 10-day period, about 50% of the time was spent in seclusion. So on the 10th day of seclusion and being highly medicated across that period, this person became distressed and was not able to be coherent at all, and they expected him to be otherwise. I won't go into the detail. So what was it about all of that experience? Why was it that he drew the short straw? What was it that they were not seeing? These are all the questions among many. So I start with an extreme example, but it's a very fundamental example of just not seeing people as human. So what I'll do now is I'll move on to the everyday things. And Piers was right. It's the many thousands of small and big things, like this big one is an example, but it's in the everyday small things that move. If we don't see the small things, then we're going to actually miss the big things, I think. So the first example, which I've got the pleasure of commencing very soon, is a lovely project by BHeart, which Lived Experience Australia and others were partnering with. And this is a very nice example with the NDIS sector in particular, with a range of different organisations. We're a mental health group, but there are many other diverse groups involved in this. So Piers was right. It's in the thousands of everyday encounters, the big and the small ways that we demonstrate humanity towards each other. So in this project, what we're going to be doing is actually sitting down with people with lived experience to create examples of actual small everyday ways that we can have encounters that are respecting human rights in everyday ways. Apparently, people need to be shown how to do this, which is a bit ironic for me, but apparently that's what's needed. Particularly in this particular area, it's interesting because choice and control is the mantra of NDIS, and yet there are many basic everyday ways that people's choices and their control are not demonstrated as basic human rights because something gets in the way of seeing them as rights-bearing humans, autonomous, etc., etc. The next example, which I'll talk to you about, is a fantastic project that we were privileged to be involved in with Tandem and RMIT, Monash Uni, and the Mental Health Friends and Families Queensland, led by Tandem. And I've got the Not Before Time report here on the side because I think this was a fantastic example of where consumers and carers actually came together to acknowledge the human rights impacts that sit across both of them, that they both share, but also the individual experiences of mental health systems and of community support systems. So the Mental Health Carers Human Rights Charter, I'm not sure that it's up on their website yet, but I can certainly point people in the direction of it if they're interested. We launched it at the most recent THEMS conference in Canberra. So what I've got here are 4 of the 8 human rights that arose from the work. So last year, the group had presented at the Carer Day at THEMS, and we asked a room of about 100 mental health carers, what do human rights look like to them? And then we came back this year and presented what they had told us as this human rights charter for carers. So some of the things that resonated for me were basic safety, that carers wanted the right to be safe in their own home, financial security and housing, the right to connections, social and community connections, a sense of belonging, and a right to identity, being seen as a person beyond the caring role, of not being just invisible in the caring role, which was interesting. The other one that I'll give you the example of is the human rights work that Piers has also mentioned. This was done by the South Australian Human Rights and Coercion Reduction Committee. I was a member along with others with lived experience in community organisations, and led by John Brayley, the Chief Psychiatrist in South Australia. So part of the South Australian Mental Health Plan has had a real focus from the beginning on human rights, wanting to embed more human rights into the everyday structure of the mental health plan, to try and get it into the language. So one of the ways that were clear to do that was to actually look at the CRPD and actually see how it could actually be applied. So I've got a snap here of some of the structure of that. So I'm just trying to get rid of the top of this screen. So you can see it's a series of checklists, and it works through the various elements of the CRPD and how they might apply to the everyday operationalisation, so that services can actually have a pragmatic checklist around, well, are we doing this? Are we doing that? How it aligns with that process. So some final thoughts from me, I guess, around all of this. What I'm trying to get to briefly in the small time that I've got is that human rights are about our obligations to each other. They're about basic dignity and respect, about being decent, whatever that means. It's some appeal to something higher than other aspects of regulations, rules, something that shouldn't need to be questioned, something that we should all know. They do transcend culture, religion, political persuasion, diversity, orientation, whatever it is. Human rights are something that shouldn't be nuanced. They should apply to anyone. So, you know, the analogy of, you know, the Titanic and being in the boat and seeing people in the water. We should fish out everyone in the water. We shouldn't be able to pick and choose who. Human rights don't mean curtailing other rights in order to be achieved. There's nothing to be frightened of here in having a Human Rights Act. It's not going to be a negative thing. It's going to be a positive thing. Human rights are about belief in the potential of the person to be autonomous and self-determining in everyday ways. So people in South Australia will know my analogy here, that I might be in a locked ward, but I still know I like peas better than beans. I still know which party I vote for. As Piers again reminded us, there's a tendency to apply deficit as a blanket, to take away all views that people can actually make choices when they're mentally unwell. It's just not the case. We can't be free at the expense of another, is another point I'd like to make. If we apply human rights, then all of us benefit. Human rights are realised in cooperation with others, how we act towards each other. They don't occur in a vacuum. So if I'm alone on an island, I wouldn't need to be talking about human rights. It's because we're interacting with each other. We realise human rights through our cooperation. And they're about striving to create the conditions that enable the other person to realise who they are or wish to be. And I'd caution that it doesn't mean that we make assumptions about what they need, because that would be coercion and paternalism. So my last questions are, does a worker lose anything by acting in a human rights way? I'd say that they lose more by not. And will we ever not need the guardrails of human rights legislation and tools? it seems that we need the guardrails. And that's where I'll leave it. Thank you.
Thank you so much, Sharon, for sharing your own experience of your the person that you cared for, and all the myriad of practical examples. I particularly liked the checklist and the question that you're leaving us with in terms of the, you know, why don't we just work within the human rights framework, and what are we going to lose? Nothing much. So we have, if I can ask Terry and Piers to rejoin us on camera, we've got our panel questions now, and there's quite a lot of questions for the remaining 15 minutes of this webinar. So I'll do my best to facilitate the questions and get as much response as we can to the questions. Some have been answered and I'll leave them alone. But there was a question here from Genevieve with the recent roundtable, and it's a little bit off HR in terms of human rights, not human resources, just to be really clear. With the recent roundtable and announcements about supposed intergovernment work on mental health, how do we ensure that the work on focus areas such as child and youth, which will be the focus for the next National Health Ministers meeting, does not lead to further gaps for those transitioning between those focus area limits and those simply outside of those restricted areas, resulting in the lack of access of care and continuity of care, and at times refusal of care for those without stable accommodation, meaning they fail basic human rights considerations, including the basic needs, e.g. Maslow's hierarchy. So I think it's a combination of how do we make sure that the gaps that we know exist and potentially can exist if we only focus on one area. So a little bit, Terry, about the socioeconomic rights that you spoke about, and how do we lift not just the human rights, but the socioeconomic rights of people. So Terry, you happy to start, and then we'll get commentary from others?
Sure, I'll be very brief. It's a great question. It's a question that goes to the grassroots level of the micro sort of actions of service providers and the relationships of service providers, their ethos of a human rights approach, the last presentation on peers, etc. And in this instance, it's actually the sort of policy choice between to move away from the siloing effect that is so dominant at federal and state level in the way services are delivered, towards a person's of the right to health, the right to mental health. It needs to implicate all of those domains, whole of government, whole of civil society, whole of community interactions approach. And there are, and Piers can talk about this perhaps, there are now ways of doing that by sharing the big data sets of and the use of artificial intelligence and so on to actually harness all of those services and programs so that the gaps are eliminated, so that there is a seamless support for a person as they move through the life cycle and so on. But it comes at a very significantly high potential risk of breaching a person's right to privacy. You know, government or services know too much about you, and you know, may enhance the stigma, and things may get worse as the attempt is made to ensure that there's a more seamless transition of government and non-government support for you.
Thanks, Terry. Piers, and then Sharon for any comments.
There's not much I would add to that, but I do think at that local service provider level is the key, and it's going to be those services and the service users who they represent who are going to be able to spot the pitfalls of focusing too much on one particular area, or they're going to be the ones who are able to report that we service users in this particular service are exiting it and unable to find housing because of this massive, you know, housing crisis or whatever it may be. Whether a Human Rights Act could provide the kind of mechanisms for them to make that point in trying to link up particular government programs. I'm less sure whether that could occur in helping people navigate these kind of state and federal mazes of particular services that are provided, but I suppose ideally they would. but it remains to be seen how that might occur. But I think that capacity of people at local service provision level to make it very clear with service users to where those gaps are and report it up the chain to make sure that it's part of those higher level intergovernmental conversations, I think is key.
Thanks, Piers. Sharon?
Yeah, probably the only thing I'd add, building on both Piers and Terry, is actually listening to the lived experience, because it's the everyday small things that workers are not even realising are on the way to disregarding basic human rights. So people are very good at raising those examples if they're listened to.
Thank you so much, Sharon. There is a question from Renee here directly for you, Piers. I appreciate the value you've placed on law expression the role communities and workforces play in safeguarding people against people accessing systems. However, the need for laws that ensure accountability to this will be imperative in ensuring safety and wellbeing to those within these systems and exercising the realms of the Commission. A federal act would cover much more of a broader scope than current existing laws in disability, mental health, and more recently, aged care. They're keen to hear your insights on that one, Piers.
Yeah, I wasn't quite sure of the question that I could answer, but I suppose, I mean, I agree with the comment, so there's not really much more I can add. The Disability Discrimination Act at the federal level is clearly has serious problems, and I think there's shared agreement on that. There's absolutely no controversy about it. And so having some reform of that to give people a proper recourse to kind of raise a claim of some kind of disability-based discrimination will be really valuable. And I think probably in the mental health context, that's likely to play out in systems of education, employment, and indeed in people's encounters with healthcare services. And there's another question here about stigma within mental health service workforce. Well, potentially those kind of discrimination claims could be brought with a strengthened recourse for that kind of claim. That's all I could really add. I mean, I'm all in favour of strengthening those discrimination provisions, which are absolutely manifestly inadequate at the moment.
Thanks, Piers. I might go to that question that talks about stigma. Given the stigma exists still in the mental health sector and is typically worse in the general medical sector and wider community, how can we educate at least the wider medical community, including mental health, to see the person and basic rights regardless whether living with mental health challenges or not? And I think, Sharon, that speaks to largely what your presentation was about, so I might hand over to you if you have any commentary to make on that one.
Yeah, I guess, my initial example is a pretty raw one, I guess, and blunt one around what happens when stigma occurs. I think lived experience people just need to speak up and tell it how it is and tell people about the impact of stigma a bit more.
Thank you. Terry?
Yes, I mean, just to go back to a point that Piers made a few minutes ago about the Victorian Royal Commission report. It's a brilliant blueprint about what happens outside mainly the law to implement the kinds of things that Sharon and the rest of us have been talking about. The really worrying thing is that the go slow or lack of commitment by the Victorian government to honouring its initial promises are principally in the area of are they honouring the co-design and empowering of people with lived experience? Well, the answer is lip service and a little bit more has been given to that. Secondly, are they moving rapidly enough on the establishment of these? I think there's 15 or different areas where a local board was to be established. Well, no board has been established as such, one that has real authority and power to do the kinds of things that Piers was talking about, to look at the gaps and give advice up upstream about new resourcing or help to coordinate things within that local community. All that's happened is that the preliminary step in 8 of the 15, I think it is, areas, there's now a group of people who talk about the issues that might be relevant to solving the local problems in those local areas. But the board itself, which would have the power and the authority to harness those voices, as I understand it, none of them anywhere in Victoria are at board level. So, and we're now 3 years, whatever it is, after the Royal Commission brought down its report, and the government and everybody else said, brilliant report, we're going to implement this speedily. Well, how much longer are consumers and people with lived experience going to be waiting around to see any real empowering of the people who matter?
Can I also add, Evelini, the peer workforce can't be the only mechanism to shift culture. This is something that all services must be accountable more and more to.
Absolutely. I was just going to share, Terry, that I know Paula is a lived experience expert in her own right, both in terms of governance. She sits on a board for Flourish, and she presented at the Thames conference last week. And I know there are, with Mental Health Australia, a carer and a consumer delegate there. So, I mean, it's a start, but we've got a long way to go. I want to reflect just for the whole group. There was a comment made by Michael, and it's strengths-based language. Disability by nature frames the experience as a deficit. Diverse ability frames the experience more positively. So I just want to acknowledge that comment was made, and total agreement here. There is a question here from, I think it's Elsa, forgive me if I've mispronounced it. If we are aware of our inherent dignity and worth, we will be able to require this in our community. Have you considered the social development and community capacity building that will occur? Any comments or questions on that one?
I mean, I'm happy to jump in as a starting point, but I think that's absolutely crucial, Elsa, and I think it's an excellent question. I suppose what you're describing is consciousness raising and community development, insofar as consciousness raising for service users to say, these are rights and entitlements, and reframing away from this kind of harsh deficit, or even arguably kind of hostile approach to psychosocial disability, mental health conditions, and so on that might appear in community and in society overall. So I think sort of redressing that as a starting point is crucial for giving people confidence to kind of claim the rights, but then also there needs to be mechanisms for them to actually do so. Turning to the community development side, or social development, community capacity building, I mean, I've very much long advocated for those kind of things, and think that's crucial to any kind of CRPD-based approach. And in my work on the Committee of Management with Belonging Matters in Victoria is a good example in the disability context of an organisation aiming to do that. But it goes to one particular article of the convention I didn't speak about, but which I do think is absolutely critical to these debates, and it's not Article 19, which is the right to live independently and participate in community. And that really does combine sort of civil and political rights by giving people freedom from sort of state intervention to tell them where they should and should not live, and then giving them and then granting economic and social and cultural rights by making a demand for a transformation of, again, mainstream norms to better reflect human diversity, which comes in all shapes and sizes and includes all manner of disabilities and things like psychosis, which are never going to be not a part of human being, because they are just part of what it means in the spectrum of human experience. So developing community capacity to respond to and incorporate those experiences is absolutely fundamental to any of these kind of discussions.
Thank you, Piers. Any other comments? Otherwise, there's a couple of more questions I want to try and smash through. There's a question from Melissa here. Do any of the panel wish to comment on the WHO statement on mental health promoting and protecting human rights that was released late in October last year, I think it is. Well, obviously last year, it's not this year. Piers, is that something that you're familiar with, would like to comment on?
Look, I'm not familiar with the precise statement, unless it's the generally part of the World Health Organization resources on guidelines for mental health legislation, and also those ones that I mentioned in my presentation on community-based services. But I mean, they're both sort of 300-page reports or something, so I don't want to hazard.
So that's our homework for tonight, is to look up that. So thanks, Melissa.
But I may be mistaken. So sorry, Melissa, for not being aware of what you're referring.
No problems. Okay, so Sharon, there's a question here for you from Anne. Is there a current program being developed for mental health persons like the Between the Flag program, Clinical Excellence Commission New South Wales, for the deteriorating patients with mental health S&S? I'm not sure what S&S is. But that's what the question asks.
I'm not familiar enough with that particular one to make any comment directly, but I'll go back to the capacity issue. You know, like in the lived experience sector, there's a lot of focus on building capacity for people to tell their story safely. And so I just want to acknowledge that that is really important work, and not to lose sight of the fact that it's so that people can actually have capacity and not be re-traumatized by the experiences that they've had in the system as well. So yeah, it's needs to be done well and done carefully for people and with people, because it's not just a case of, yes, we build people's capacity to speak up. There's a lot to do with that.
Thank you, Sharon. And I've just learned, thanks, Anne, for clarifying that S&S stands for signs and symptoms. So I think it'll also be helpful to understand what role potentially with the review of the New South Wales Mental Health Commission, whether that will increase their scope. Now, I know that I am drawing very quickly to the end of our panel questions or Q&A, and I realise there are some questions still sitting there, but I just want to take this opportunity to thank our panellists for being present to present their views, but also for the Q&A. So please join me in thanking our panellists, Terry, Sharon and Piers. This webinar will be available in a few days from MHCC's website. The presenters have, as I said earlier in the session, given permission to share their presentations. And at the end of the webinar, a survey evaluation will be available for you to help inform what other topics you'd like to hear about. So thank you again. I hope you have a lovely day to our panellists and to all our attendees today. I hope that you have a lovely afternoon. Thank you for your time.